Hello everyone. My name is Beth Jones. I am a family medicine physician and faculty at the University of Michigan Medical School. I'll start out with talking, but maybe I'll have Dr. Haidar and Sarah Harvin both just briefly introduce who you are, but you'll be hearing from them more soon.
I'm Aseel Haidar. I am finishing up my second year of residency at the University of Michigan. I'll be a third year in like 2 weeks. And obviously, I'm a resident in the Department of Family Medicine.
Hi, my name is Sarah Harvin. I'm currently, I guess, a third or fourth year at the University of Michigan Medical School. I'm doing a research leave of absence, so taking some time off between the last couple of years.
Okay, so our goals today is to talk a little bit about what is family medicine, and then we'll tell you about each of our journeys to family medicine, and then a couple of cases, or if we have time, and then definitely time for questions. Some of our slides are coming from the American Academy of Family Physicians, which is our national group that has a lot of really good information if you're interested, it has pre-med student information there as well. But family medicine we're a specialty where we see patients regardless of sex assigned at birth, age, and presenting complaint, right? So we see all patients, we see them inpatient, outpatient, we deliver babies, and we do procedures. And we really think of the importance of that. And I'd say like a core tenet of that, and one of the reasons many of us are interested in that is because of the continuity of care, really getting to know an entire family. So there are many, many types of doctors. You guys are going to hear about them over these next several months, but this is really the only specialty where we really take care of people from that primary care lens across the lifespan, right? Um, we also find it to be really important to think about a person in the context of their community, right? So family medicine physicians really find it important to be engaged in their community, knowing what resources their patients have, and thinking about the community both for the patient and on an advocacy level. So that'll probably come through as a lot of us, as we talk through a lot of our journeys. But I think maybe if that, brings up questions for you, like I say, we will have them at the end. Also, please feel free to use the chat and we'll kind of keep track of those too as we go along. So go to the next one. First, we'll start with me, and basically, I think my story is one to talk about family medicine plus academic family medicine and education, right? So my story, I would say, is actually not what you would consider the story of all family medicine doctors. And in fact, I think that's what's actually one thing that's really great about family medicine is that it's so variable that you will talk to 10 family doctors and hear 10 different stories, right? Because everyone is able to kind of adjust their career to be they want it to be. Um, but I am an associate professor here at the University of Michigan. I have a really strong interest in education, and that's why I stayed in academic medicine, was in order to both see my patients, but also teach medical students mainly, although I teach the residents as well. So my main two roles right now is that I'm the director of our medical student education here at Michigan. So run our clerkship, the family medicine clerkship, if you've heard of that. That's when the medical students all do sort of their core rotations and do different specialties. And then I'm also the co-director of something called the Patients and Populations branch. So that's not specific to family medicine. But as Sarah might talk about a little bit, during medical school in the third and fourth years, students have a little bit of an opportunity to quote unquote branch out and try different things and make it a little more individual. And one of those is called Patients and Populations. And that's, again, very important. We think about the community, we think about things like health insurance systems, we think about things like structural determinants of health. And it's sort of a co-curricular type of thing. So we can go to the next one. Me personally, I am a Michigander. I haven't left to live anywhere else. I actually haven't left Southeast Michigan to live anywhere else, but so that's why I think probably why my family and I love to travel so much. But I grew up just north of Detroit and went to Wayne State for my undergrad. And while I was there, I did all of my pre-med stuff was with the goal actually of being a pediatrician. I did all of kind of my shadowing. I did a lot of research at Children's Hospital of Michigan. I got a lot of really great experience. I worked with a pediatrician who was doing a lot of work in the community in Detroit where we would actually take this van and go to schools and offer developmental screenings and vaccinations and some kind of basic care for people that were having like transportation or insurance issues at the time. And I loved it. Um, and so with that in mind, I decided to go to Wayne State for medical school as well, because I did think, well, for pediatrics and for primary care, I thought, that would be a great school. And I did. I had a great experience while I was there. And I think this is one trend you might see as you hear everyone talking. I went through all of my clerkships, as we say, right? So surgery, and I went through internal medicine, which is where you see adults, and OBGYN, and every rotation, I just really found pieces that I just enjoyed so much. And I couldn't see myself giving that up as a doctor later in my career. So I think just like listening to that little voice as you guys are going along and doing different things of like, it didn't mean that it was the most fun rotation, right? Or whatever, but it was the thing that felt like the most fulfilling or the most interesting, right? So that kept happening to me where I was like, I don't know that I can quote unquote give up adult medicine. And so that got me really thinking about, well, what are the things where I could put together everything that I liked? And one of my friends was actually part of the family medicine interest group. Almost all med schools have those, and it's really just a fun thing where like after, in the evenings or something, they would have events where they would have family doctors talk about their life, or we would do suturing sessions and practice stitching up a chicken leg or something like that, and or casting each other, put casts on each other's arms. And it was it really kind of was like, oh, I think I could put this all together in family medicine, all of the things that are most interesting to me. And I was thinking, well, I want broad, and I really like to be the first person to see someone. So I went and did my emergency medicine rotation. And every day I would come in for a shift and I would say to the attendings or whatever, so like, what happened to that person yesterday that we saw yesterday, And the attendings, and it was nothing wrong, but they would be like, listen, no, we're focusing on today, right? This is the ER. It's a fast pace and we're moving on to the next thing. And again, I had to listen to that little voice that was saying, no, you want to have that continuity, you want to have that relationship, and being able to always be part of a patient's life, throughout time. So even if they do need to go off and see a surgeon and get that surgery, they come back to me and talk to me, and we help them through those times. So that's what helped me decide family medicine. So I knew I wanted to stay in Southeast Michigan because of that for residency. So after graduating medical school, choosing a residency, you'll hear more about that. But so I stayed and made the move over to University of Michigan. And as many of you have probably heard, this place kind of keeps you once you're here. It's really a lot of great people. And so I came here for residency. And because of my interest in academics, I stayed for a fellowship and then became faculty here and have built my career there. Next slide. Okay. We thought it'd be interesting just to give you a quick example of what a week might look like. One more behind. So I think the fun thing about my job is that this is just a random example of a week, but it looks different all the time. I actually love that about my job. I have a lot of control over what that looks like, but on a Monday morning, I'm at the medical school with the medical students talking about their clerkship. I do a didactic session where I teach about like cancer screening and prevention and, checking blood pressures and things like that. And then I work with our students with Wolverine Street Medicine, as we call it. So on a Monday afternoon, I might be in Ipsy, working with our students to see the unhoused population there and help and try to help there. On Tuesdays, I might have some administrative meetings. We might be working on some new education pilots, right, to try some new curricular changes, and I really enjoy that. And then in the afternoon, my patients I see in Livonia, actually, which is another suburb, so it's about 30 minutes east of Ann Arbor. And then we have grand rounds where we teach each other, and that's really great. Another reason I love staying in academics. And then Aseel knows I work with our residents on Wednesday afternoons. I go to our IPSI clinic and see patients with our residents. And so you can just see, it's just every day is a little bit different. I might be in IPSI, Ann Arbor, Livonia, and I enjoy it. So you can go to the next one. And then, so when I'm in clinic, as people might say, we always say, oh, I have clinic. That means in the clinic, seeing my patients in the outpatient setting. So like your primary care doctor, you have a doctor, you know, need your checkup, that's where you go. And so this might be an example of my schedule for tomorrow morning. And you can see it's just like across the whole age spectrum, there might be someone there for a checkup. And by the way, oh, by the way, also, you know, my ear hurts or I have a rash. There's a lot of chronic disease management, as we call it, right? So people who have high blood pressure or diabetes, people that have depression or anxiety, and sometimes, like the last one, the 3-year-old comes in and 3-year-old's having a cough. And well, you know what? Actually, the 6-month-old and the mom are both my patients. And, you know, they're having a cough too. So maybe we should listen to their lungs as well. And we kind of just take care of everybody at that same time. So, go to the next one. I mentioned procedures. I think that's a question we get a lot from our learners is, you know, they're really interested in, you know, working with their hands, or they liked doing procedures, say they shadowed maybe a surgeon or something like that. So there are many, many procedures. That was actually part of the reason I ended up really liking family medicine. I loved dermatology actually, and doing skin biopsies in particular. So you can see the list here of a lot of procedures that family doctors will perform in the outpatient setting. I'd say the main ones that you would see family doctors doing inpatient is that you can do extra training and become C-section trained, actually, because family doctors are trained to deliver babies, but to have that extra training to do the C-sections in the operating room is an extra year fellowship. I personally mainly stick with these ones at the top. A lot of skin procedures, biopsies, injections into like the shoulder or knee if someone needs a steroid injection. Um, there's many others. A lot of IUDs and other like contraceptive procedures like Nexplanons, if you guys have heard of those. So I'm going to hand it over to Dr. Haidar.
Yeah. So like I said earlier, I'm in my finishing up my second year of residency, about to start my last. To kind of get to where Dr. Jones is now, you have to go through a family medicine residency. Um, Family medicine residency is 3 years long, very broad spectrum training, which will obviously vary depending on what program you go to, even like the state you live in. Are you in an urban city setting? Are you more rural? You'll find variations there. But for the most part, especially in that first year, there are like requirements that every family medicine resident has to meet. So very often that first year you can think of as like a foundation year. You're doing a lot of basic inpatient medicine. You're on the adult side. For a few months over the course of the year, you do inpatient pediatric medicine. You do a bulk of your OB/GYN training in that year. You will likely get assigned a longitudinal or get assigned to a clinic site for like a longitudinal clinic experience. That's going to be a requirement regardless of what family medicine residency you go to. Kind of seeing your own patients in a clinic over the course of 3 years, you need to have that longitudinal relationship with them. And then you'll have some other outpatient experiences and things like outpatient pediatrics, psychiatry. Everyone will do adult emergency medicine. Everyone will do pediatric emergency medicine. And a lot of that will make up the bulk of your first year. In the second and third years, you tend to have more time on family medicine services. So you're spending less time with like off-service residents who are doing cardiology or OB/GYN, but you're working more with the family medicine department, You kind of have more of a say in where you're spending your time, which has been like my favorite part is getting electives to dive deeper into the things that I find interesting, which could be like primary care, gynecology, community medicine, sports medicine, obesity medicine, geriatrics. There's so much to choose from. And you do a lot more of that in your second and third year. Lots of programs will have like leadership development in their curriculum. You'll spend a lot more time in your own continuity clinic, seeing your patients and just getting to build those relationships. But you'll see on this slide is like a good outline for a family medicine residency program and pretty similar to the one that I'm in right now. Um, this is kind of my journey to where I am today. There's literally just a block M because a lot of my time, literally the last 11 years of my life, have been here in Ann Arbor. I was born and raised in Dearborn, Michigan. I'm actually in Dearborn today, so like very close to home. I went to Fordson High School, graduated in 2014, and then I attended the University of Michigan for undergrad. Pre-med track the whole way, but didn't really know what kind of medicine I wanted to practice and was really just focused on getting into med school because getting into med school is hard. And so that's kind of where my mind was at that time. But I graduated in 2018 and then took a year off. I know it was pretty popular to take one gap year back then. And I know people are taking more time off before they apply to med school now. But in that gap year, I worked as a psychiatric care worker again at Michigan Medicine, but in the psychiatry department because I thought that was a field I might be interested in. And it was like a good clinical opportunity while I worked on my to get experience while I worked on my medical school applications. And then I was accepted to the University of Michigan Medical School. And I spent 4 years there. And again, once you're kind of in the U of M system, it's really hard to leave, obviously, and ended up staying here for residency. Things that like couple things, I guess, why I chose this residency. We have a union here, which you might not totally understand what that means now, but basically residents work a lot and it's important to have support in that time period. And the union here just supports the residents to make sure, we're not working over our duty hours, to make sure that we have the things that we need to be successful, support from our faculty and things like that. Making sure we're treated fairly in the workplace and so on and so forth. And that's very unique to the University of Michigan and maybe a handful of other programs in the country. And then, why family medicine, similar to what Dr. Jones was saying, went through all of the clerkships, could find something I liked about all of them. But the thing for me that I consistently found myself enjoying in every single one of those rotations, whether it was surgery or OBGYN or psych, was I always thrived in the outpatient setting, the workflow, going like the back to back to back appointments, getting to see 15 to 20 people in a day, different people in a day. And then the thought of getting to see them again and following up and, okay, so how are you doing since we last came up with that treatment plan? Are you feeling better? What's next? What came of the labs that we collected? What did we come up with a diagnosis together? Oh, you want to bring your sister in? Cool, I'll take care of her. Just like getting to do that was super cool to me. And then the flexibility of family medicine, I don't love everything about adult medicine. There are things that I don't love, and you can kind of cater your practice to that. I especially enjoy taking care of like reproductive age women and then also postmenopausal. They're like two very specific populations with very different like experiences, and I love taking care of both of them, but I also love taking care of the patients in weight management clinic, and I can make that half my panel if I want to in family medicine. And in 10 years, if I change my mind, I can change my mind. And so just really love that flexibility. And that's why I'm 2 years into my family medicine training and now having to think about what I want to do when I graduate. So, what am I going to do when I graduate? And that's kind of why I have the TBD question mark, question mark. I think I have an idea, but toying with the idea of fellowships, you're going straight into a job, which takes me to this slide, right? So, what if you're in family medicine, but you have a very specific area of interest? Within family medicine, there are so many different fellowships or additional trainings that you can pursue. You can get board certified in a lot of these without doing a fellowship, especially if, that fellowship doesn't exist and you have to do your own education. There's a lot of educational resources online where you can get certified and then study for an exam and have these additional certificates to like add to your resume and show to your patients like, hey, this is something I really care about and something I really want to do. And I have expertise in this field in addition to my training in family medicine. And so it could be something like addiction medicine, geriatrics, so seeing like older patients. Lots of people who graduate from my program go into inpatient medicine and actually work in the hospital, not just clinic. A lot of people go on to deliver babies and do C-sections. And so you can really take family medicine and make it whatever you want. I mean, if you can even go out in rural practice and there are family medicine doctors doing like um, colonoscopies and things like that, which like blows my mind. And so just knowing that, even though you're going to a very broad field, you can make it specialized if you want. For me, though, I don't know if I'll get that specialized or if you'll see me doing colonoscopies. I do hope that one day I'll end up just like in a community-based clinic, is my goal. And so then just to kind of touch on like a week in the life of a family medicine resident, which really can vary depending on like what time of year it is. Similar to medical school, you're doing rotations throughout your whole residency, right? Here at U of M, our rotations are 2 weeks at a time. A lot of other places will do them 1 month at a time, but I've really enjoyed the 2 week long rotations. Typically, you'll do, especially in the intern year, you'll do 2 weeks on inpatient medicine, and then transition to outpatient after that. It's the outpatient weeks that really can vary by the day. And so maybe on Monday, I'm in my continuity clinic at Ypsilanti Health Center, which is where I'm based out of, and I'll see my own patients. Tuesday, I just discharged some patients from the hospital last week, right? And so, of course, after you're discharged from the hospital, you need to see your primary care doctor's office just to, figure out, talk about what happened and see how you're doing and make sure we keep you out of the hospital. And so I'll see you in discharge clinic and follow up with you there. On Wednesday mornings, we have our weekly, could be grand rounds or resident didactics, so just lectures so that we're getting learning on a weekly basis. In that afternoon, we might go do home visits with an attending because there's actually a lot of patients out there who can't go out and see a doctor, and the doctor will actually come to their home, which is really awesome. If I am free in an afternoon, and I might get paged about a continuity delivery. So, in family medicine, we're also taking care of patients who are pregnant. And one thing we try to do is when one of our patients goes into labor, the person who's seeing them at the hospital checks and sees, okay, who was taking care of this person throughout their pregnancy? I have to page them and let them know that so-and-so is here to have a baby in case they want to be there and help deliver the baby. And so if I get paged that my patient is ready to have their baby, and I have the time, I can go and be there for them, which is really awesome and full circle and rare, but beautiful when it happens. And then my favorite thing is just to have like a half day of admin time to just catch up on my notes and my, in basket as a family medicine doctor, you can get messages from patients. You have test results to follow up on, and that's called in basket management, which of course takes time. But lots that can be happening in just a week. And then I'll pass it on to Sarah to talk about her experience as a medical student.
Great. So we wanted to start off just by kind of going over the basics of medical school. So most medical school programs will be a minimum of 4 years unless you do a combined program. I think Wayne State had one when I was applying where they combine a bachelor's and your MD together. But most medical students will spend 4 years completing their medical school training unless they do research years or dual degree programs. And most of medical school will be focused on just building general medical clinical knowledge and exposing you to as much as possible. And so I included a diagram of Michigan's curriculum. Well, yeah, an overview of the curriculum. So the first year you'll see on the left side is the scientific trunk. So this is where this is your preclinical year where you're just learning as much as possible about the organ systems, anatomy, medicines, different pathologies and everything. And then Michigan also has kind of some longitudinal courses that also go along with that. So you'll be in your chief concern course where you learn a little bit about clinical reasoning skills. You have your doctoring group that you're with the entire time, where you'll learn physical exams and just kind of like practice actually doctoring patients. And then there's some other kind of introductory, longitudinal courses to like your capstone for impact. You'll do an interprofessional education course where you get to learn about other healthcare workers and different colleagues and everything. And then after that first preclinical year, you get into your clinical trunk, which is also a year long. And that's where you kind of explore the 7 main clerkships. So you'll do internal medicine, which is basically adult medicine, hospital or inpatient as we call it, and then also outpatient. You'll do rotations on surgery, neurology, family med, psychiatry, pediatrics, and then OB-GYN as well. And then after your second year, you'll do your board exams. You need to pass both of them. We call them step 1 and step 2. And those are 2 of the 3 exams that you need to become a fully fledged doctor. And then after those exams, you get into the branches where you can really kind of curate your own path out of medical school. So you choose any clinical electives that you're interested in exploring more. So if you're, for example, interested in family medicine like I am, we have family medicine electives that you can do. I did an outpatient orthopedics rotation, which was really awesome, just to learn about just sports medicine and kind of what that looks like in the outpatient. And then you'll do rotations in ICU. You'll do rotations that are called sub-internships, where you get a little bit more responsibility as a medical student, just to kind of help you prepare to eventually be a first-year resident. And so, yeah, and so all while you're doing that, you're also kind of continuing, any capstone projects that you started, any different paths that you've chosen to kind of, I guess they're co-curricular elements, I guess I'll call them. Everything essentially in the branches, as we call it, is based on developing any interest that you have and building as many skills as you want, essentially. And then I guess we can go to the next one. So my journey is a little bit of a winding road, a little bit. So I went to Hope College, which is a small private school on the west side of Michigan. I got a bachelor's in psychology, did research, sailed a little bit. Those are just, I guess, extracurriculars that I thought were interesting. And then I actually ended up taking 5 gap or growth years. I was fairly certain I wanted to do medicine, but I had taken a job as a patient care tech in a hospital, which actually got me really interested in nursing for a long time. And so I essentially was deciding which route in healthcare I wanted to take, nursing versus medicine. I did a master's in narrative medicine in New York, which helped me learn more about like health justice and advocacy, social determinants of health. And ultimately that program kind of helped me decide on medicine because I felt like medicine put me more in the decision-making role, ultimately, and that's kind of what I wanted. It also kind of hit on the depth and breadth of information that I wanted. So I was really interested in learning why diseases work the way that they do, why we choose the medications that we do. And I thought that medical school was the best option for me. Currently, I'm an M3/4 doing a research year here. I finished all of my 7 core clerkships, including emergency medicine, and just decided to take some time to focus on some independent research. Currently, I'm planning on applying into family medicine or family medicine and emergency medicine. There are a few dual programs that allow you to do both. Sweet. And then a day week in the life of a medical student is pretty straightforward. So for the preclinical year here at Michigan, a lot of the lectures are asynchronous or pre-recorded. So it gives you a lot of flexibility in terms of when you want to do lectures. Throughout the week, as you'll see kind of on the schedule here, you do have some in-person obligations. So you'll do anatomy lab, typically in the mornings. You'll have your doctoring groups either on Tuesday or Thursday, not both days. So you'll meet with your doctoring faculty and your doctoring group to kind of go over different physical exams, depending on which block you're in. And then you also have some in-person small groups where you get to chat over case studies and really kind of like hammer home the points that you're supposed to be learning in. And then at Michigan, I think the quiz, I want to say they're every other week, but typically the quiz will open on Friday afternoon. And some people take them right away as soon as they open on Friday afternoon, and then other people will take them Sunday night. So it kind of just depends on your personal preference. And I think I've really kind of enjoyed that flexibility, especially in the early stages of the curriculum. You're able to really kind of tailor your schedule for what works. Cool. And then just to give you a brief snapshot of a clinical schedule, this was actually, I want to say my schedule for family medicine. For family medicine, I was at Packard Health, which is a health, I guess, I think there's 3 clinics here in the area that I kind of rotated through. So essentially, you'll either do a full day of clinic or a half day of clinic, depending on the day and just kind of lectures that they have scheduled for the week. What I enjoyed about family medicine was that I got to rotate with a lot of different providers, which gives you a good idea of, there's not one way to practice medicine, which I really appreciated. Everyone kind of has their different like different paces, different tempos, different styles of interacting with patients, and that was really good for me to see. Let's see. I think family med, you get weekends off, so that was great. And then in the clinical years, there's usually a decent amount of whether it's half days or lectures that they incorporate in the schedule, there's a decent amount of time to do learning in addition to your clinical time to prepare for the exams that happen with every block. So.
Okay, so maybe go. So we're going to start with a couple case studies, and I'm just going to have you guys think about what you might have be thinking as we go along here, right? So, I have a patient. This is a year ago, almost exactly. 62-year-old man with a history of type 1 diabetes. He comes in for his checkup, right? So, like you guys going for your yearly exam, your checkup. And so we're going through all the normal things, right? So healthy diet and exercise, and you're not smoking and all the things, and your vaccine. And he mentions, well, my wife wanted me to mention to you that, we go on a daily walk. We usually go for 3 or 4 miles, no problem. But, for the last couple of months, I get to about the 1 mile mark and I just feel really tired. It's like, I just think, I'm getting older, doc. I think I'm fine. I probably just need to exercise more. But I'm maybe a little more concerned than that, right? And so we're wondering, as you're listening to him, what diagnoses would you be thinking about? You don't have to say them out loud. You just start thinking in your mind. And I'd say, oftentimes, the way we start, I was a doctoring faculty actually for many years, and the way we have students start to think about this is one of multiple different ways, but oftentimes a systems-based approach, right? So thinking about what systems could be involved here. So cardiac or heart, pulmonary or lungs, hematologic, meaning like anemia or some sort of other like blood disorder that could be happening. Many other things. I would say my general approach. So these types of things, people come into you in primary care and family medicine and they can say anything, right? They could come in with I had a patient last week who had a dislocated toe. So I think, it could just be anything. So for me, the general approach in primary care is if I can always think about what is the most common thing that could be going on and what's the most concerning thing that could be going on, I am in general going to be pretty covered, right? Thinking about those things. So here, I want to think about what his risk factors are. And in particular, we know that people with diabetes of either type have significant increased risk of heart disease, right? So I said, I'm concerned. I do think maybe you do just need to exercise more, but why don't we go ahead and get a stress test? Okay. So he says, sure, that's fine. I'll go ahead and I'll get a stress test. They paged me from the stress lab to say, like, this is wildly abnormal. Like, there is concern for blockages in multiple of the blood vessels around his heart, and we need to actually send him directly to the hospital. He goes to the hospital, sees the cardiologist there, and they recommend a cabbage. You folks might have heard of that before. So coronary artery bypass grafting or a bypass surgery. That's what people often will call it, right? They say, oh, I had heart bypass surgery. And that's a big surgery, right? So they have to actually go in and they open up your chest. They put you on the machine to bypass the heart and lungs while they go in and they literally, go past these vessels that are stenosed or clogged. And he says, no, I don't want to do that. He's in the hospital and he's talking to the cardiologist. He's talking to the cardiothoracic surgeons. And he says, no, I'm going to go home. I feel okay. I don't want to do that. So I call him when I get this information and I just say, like, we've known each other for 10 years. What's going on? Right? Yes, you have diabetes, but overall, like, you're an active person. You were walking 3 to 4 miles. Um, what's the concern here, right? And he said, I was diagnosed with type 1 diabetes. And I actually, so me as a family doctor who takes care of lots of patients with diabetes, I wasn't around 50 years ago when what he was told when he was diagnosed with type 1 diabetes is you probably won't live past 40, right? It was treated very differently. Like we had insulin, but not all the things that we have now. And there were all these complications. And so he said, I've just always been feeling like I've been waiting for that other shoe to drop. And this feels like that's what it is. And maybe this is my time. And so we had this just really nice conversation. And because we sort of knew each other and he trusted me and I knew him well enough to say, like, I'll be really blunt with you. Like, if that's how you feel, like that's your decision. But actually, it doesn't mean you might just drop dead someday. Like, we were very blunt with each other. Like, you could also have a heart attack that would not kill you and that would leave you very much unable to do all the things that you want to do. I am his wife's PCP. I'm his brother's PCP. I'm his sister-in-law's PCP, right? Like, I know this family. And so he went and had his cabbage. And so I just saw him 2 months ago for his year. He was like, I'm actually nervous to be here. It's been a year. What else are we going to find? Actually, it's the first thing he said when he came in. But he was doing great. He said, it was hard in the beginning. It was a big change. We talked a lot about that. We know there's a lot of actually depression in patients after big heart surgeries. And we talked about that type of thing. But he said, I'm able to walk around and pick up my grandkid and swing him around. And so it was really, I think in the end, overall a really a good outcome. So I think to the next slide, I'd say, things that I'd highlight here. First of all, as a primary care physician, we're always thinking about what are our risk factors, right? And how do we mitigate those risk factors? And our goal is prevention. So maybe it's not as quote unquote exciting, right? To talk about diet and exercise and give them medications to lower their blood pressure and control their diabetes. But if I do my job well, that patient doesn't have that first stroke or doesn't have that first heart attack, right? And that's really our goal. And I think that it really also highlights that continuity of care when you know someone over many years. They're much, not always, but like obviously people have great relationships with their specialists and surgeons, but the number of times that I have a patient come to say, like, listen, I went and saw the surgeon, but I've only just met them the one time and it seems like a good plan, but what do you think? And to just be that person that they know is going to be there for them and can help them through whatever life throws at them. So, okay. That's case one. We could probably actually, I think probably 5 minutes for case two, and then we'd have 10 minutes for questions. Does that sound okay, Arvind? Okay.
Yeah. I have not had as many experiences like that as Dr. Jones has, but I'm very early in my career and hopefully we'll have stories like that to share. I was just going to share an experience with a patient of mine. She is a 27-year-old female. I was following her for mood symptoms in clinic. I'm not her regular PCP, but after we had a really good visit, because you could see anyone at the office when you're scheduling an appointment for like a specific concern. She had like worsening anxiety and depression. We had a really good visit where I just kind of learned about her, what she was experiencing, didn't necessarily start a medication, had like talked about non like pharmacologic treatments like therapy, exercise, and was able to schedule her for follow-up with me. But while I was following her with her for her mood symptoms, she got pregnant. This was her third pregnancy, so she had been pregnant before. But eventually, we did decide to start a medication for her depression and anxiety. But now we had to consider the fact that, oh, like she's also pregnant. And so it was safe for her to continue that medication while she was pregnant. I, for like, at that follow-up appointment, talked a little bit about the impact of her pregnancy on her mental health. And based on the relationship we had developed after just a couple of visits, she decided that she, along with her, primary care, she also wanted to get her obstetric care through our department after she had previously seen OBGYN. And, she's relatively young, healthy patient, and we see lots of low risk pregnancies in our clinic and ultimately end up delivering them as well. And so I was able to, see her for her regular medical problems, but then also be her obstetric care provider and see her for a majority of her prenatal visits because I'm very aggressive about rescheduling people with me specifically. I get attached to my patients. And so then when it was finally time for her to have her baby, I think she had her baby around the holidays. And I was also working on our FMB or family mother baby service at that time. I wasn't on, but I did get paged when she came in and when she was closer to time of delivery. I was able to join the resident who was also on service, and we delivered her baby with the family medicine department. So was able to take care of her in multiple capacities. And then it gets even better. So she has her baby, right? And now her baby needs a doctor. And so when we deliver our patients' babies, we ask them, who do you want your baby's primary care doctor to be? And she wanted her baby to be seen by myself and our clinic at the Ypsilanti Health Center, which was really awesome and rewarding. And I don't really think you get to do that in any other specialty, right? Like, um, the pediatricians get to take care of the babies and the obstetrics providers take care of the pregnant patients, but then we can do both, which I think is one of the best things about family medicine. And I think that,
We're ready for questions. So we thought,
yeah.
yeah, leave time for any of the three of us and about any of it. Honestly, med school, residency, being a family doctor, being a doctor. Um, how random is it? So we actually residency matching. Good question. There's a lot of talk, and Aseel can talk to this too a little bit. But I actually do a lot of advising. It's a big part of my job is advising students into the match. And so the match process, as you've heard about, is we say a little bit on the student side, meaning that if there's a tie, the tiebreaker goes to the student's decision. So in family medicine, there are over 800 residency programs in the country, far more than any other specialty. So actually, what's actually hard for our students is to really decide. You're not going to apply to all of those, right? You don't need to. So they how to find the programs that best fit their needs. Seal, would you add anything to that?
Um, I would say in terms of how like the randomness, if you mean like of where you end up, um, it can be a little random, right? Because I provide a list of like my top 10 or top 15 or however many programs from 1 to 15 of like where I want to end up at the most to the least, and then the programs kind of do the same thing. So there's some uh intent from both sides. So hopefully it doesn't feel random when you get the match,
Yeah.
but it is quite different from any other job where you get a job offer and you accept it or decline it. It doesn't really work that way. So there's some randomness to that, I would say. But yeah, we are lucky in that there are so many seats, right? And that hopefully, like most people end up going, matching if they interviewed in enough programs.
I'm gonna put a couple of these questions together that I can answer, and then maybe ask Sarah to. I'm gonna put a couple of the ones together for Sarah, but My fellowship, and then probably that goes well with this idea of pivoting later and how would you do another fellowship. So my fellowship specifically was called an academic fellowship. It was a 1 year fellowship after finishing residency. It does not come with what's called ACGME requirements. So there are certain ones where when you're like Aseel has on her thing PGY2, so that's post grad year 2, and you'll also see house officer 2. So that's the second year after medical school. So some residencies, like sports med, is a really good example. It's basically your 4th year of residency. You just go and keep doing that. My residency was academics, which is where I actually became an attending. I had a salary, I saw my own patients, but I had only half of my time was that, and the other half was carved out fully to like do training in educational pedagogy and take part in some of the medical school things to basically get me more immersed in academic medicine specifically and becoming like a teacher in family medicine was sort of what that fellowship looked like. Pivoting later in career. So if I decided to pivot, I would say personally, I don't think I would need a fellowship. Some people do decide to do that. That's kind of the beauty of family medicine, actually, is that because we're trained so broadly, you basically just start to learn things. So I'll give you an example. I have been out of medical school since 2008 and have made some minor changes over time and really been focused on education. But a clinical thing that I don't know how to do is POCUS. So that's point of care ultrasound, which is becoming more and more common and really cool for patients because it helps with access to care. We have a POCUS fellowship. So we have a resident right now or fellow who's being a POCUS trained for a year. However, I'm just learning it. I'm just doing, so I did some extra training, I did some extra sessions, and now I'm practicing on my own and also with some help from our POCUS team. So I'm not getting any certain special certification. I'm not doing a fellowship, but it's going to be a new clinical skill that I'll just have that I can use in my practice. Certainly, some people do decide, like, oh, I actually would really like to do hospice and palliative medicine. That's a good one that I think a lot of people decide later they're really interested in and then go do a fellowship. And then, so Sarah, I thought that this question about what is something you wish you knew before going into med school as a pre-med student would be maybe helpful. And then thinking about like, what do you think of as qualities as successful med students? Maybe you could speak to a couple of those.
Yeah, I think in terms of quality of successful medical students, I think I would say, especially throughout my clinical year, I think that I've learned to um, I've learned how to accept feedback and be grateful for good feedback. Um, I think it's sometimes hard, when someone tells you, here's a list of things you could do better. But I think that kind of ties into, I think the first question of, I think I would have, let's see, before I started medical school, I, looking back now, I know it's important to kind of understand, um, I think who you are, because you're receiving feedback from so many places, that knowing who you are, knowing what you value, knowing your goals ultimately will help you tune into the feedback that's helpful versus the feedback that's not necessarily as helpful. Because you'll get, a lot of instruction on how to do different things. But at the end of the day, everyone does something a little bit differently, right? And so sometimes you get feedback saying like, oh, you should do this, or, pursue this, or don't pursue that. This is not really good for you. But I think at the end of the day, if you're like confident in your convictions and in your values, then like taking helpful advice becomes easier.
Seal, anything to add? I'm kind of peeking through these questions. They're so good.
Yeah, they are. I'm like trying to answer some in the chat. I saw that the second part of that question, something you wish you knew as a med student going into residency.
Mm-hmm.
Um, that's a good question. As a med student, I think I like hoped for this and I kind of knew this and it just like was affirmed in residency. But something I wish more people knew in med school is like, grades are important. Well, not grades are important. It's important to learn the material. You don't have to get the best grade. You don't have to have the highest GPA. You don't need the highest test score. You just need to learn it. But the things that will take you farther are the doctoring skills or the communication skills or how you make a patient feel. Everybody's smart, everybody studied hard. Like patients will meet doctors and think that they're not going to walk away being like, wow, they're just like the smartest person, right? But they got the best score. But they're going to walk away and remember how you listened to them and how you talked to them and how you made them feel like a person and not a number. And, even if you only have like 8 minutes with someone, you can really make those 8 minutes mean a lot to that patient. And so, like, I really tried to approach my rotations like that because I wasn't getting the best grades, but I was like doing what I needed to do to learn. And then I started residency and I was like, oh, yeah, like I was right because um you know everybody, if you don't know something, you can just look it up. We look up things on up to date all the time, and then with practice you just remember it. But like it's really hard to teach someone how to have empathy or how to make someone feel welcomed or how to connect. And that, those are the skills that will take you further in med school and in residency, especially in residency.
Totally agree. I think to this last point, and also something I was just thinking is something I wish that I had known both, I think probably as a pre-med student, but definitely as a medical student, is like you will end up in a place where you are going to be happy and you're going to be a physician, right? Like I actually think that it's a bit of a myth that we talk about specialties, and I'm glad, hopefully you guys will go to other ones, months of these. Like we talk about it, it's like Cinderella's slipper or something. Like there's this perfect fit, and if you don't find it, that's it. You're going to be not happy. And it's like, I think there are probably multiple specialties that I could have created a career that I could be happy in, right? It's mostly for me about finding what are the things that I really were important to me. So continuity of care, relationships, mainly in outpatient care, this idea of healthcare prevention. I happened to find a career, like I ended up in family medicine where I firmly believe I was meant to be. I love my job. Um, but I do think we put so much pressure on it that people start to just get so anxious, like try out different things. And to this point of, so when I was in medical school, even, being at Wayne, that was at that time very much considered a primary care school, I would get this same thing like, oh, you're so smart, you should be a specialist. And
Mm-hmm.
actually, I didn't even put this on my journey because it was like such a blip, but because of that, because I kept getting that over and over again, actually, I decided, you know what, I'm gonna be a dermatologist. That's what I'm gonna do. That's a quote unquote competitive specialty, and
Yeah.
I like skin biopsies. So I went and I did an elective in dermatology, and it was really helpful to go do that because I really did like it. I liked the topics, but I didn't like the super specialized side of it. I actually didn't. Didn't like the biologics for pemphigus. I liked treating acne and looking at moles and removing skin lesions and talking to patients. And it's funny you call it about beyond the stethoscope. Like I actually just didn't feel like myself as what I pictured as a doctor not taking my stethoscope to work every day. It sounds so simple, but it just wasn't for me, right? And so I also do just want to say out loud that part of the reason that people even say that stuff is because of money, and we don't talk about money enough when we talk about going into medicine. Um, and that is because if you look in the thing, right, that like there are specialties that make more money than primary care. Actually, though, we're definitely in the middle when you look at like a lot of the more non-surgical specialties, actually. And I will tell you, I don't know about all of you, no one in my family was a doctor growing up. I make way more money than I could have ever anticipated making when I was growing up. I make a very comfortable salary and do it with a job that I love. But I do think that that's where a lot of that stuff comes from, is that people put value based on like how much money someone's making. But I think my career has so far outweighed any of that that it's never really been a thing that I've ever looked back on and been worried about, if that makes sense. Yeah. Um, and you'll get the backwards where people are like, oh, it's just too much to know. Well, it is very broad, but I think that we know a lot about our patients and help them get to the right place if needed, if we get to the limit of my knowledge. That's kind of the way I usually look at it. Um, yeah. So you could be a board certified specialist in the things we listed. So there are things from family medicine, so sports medicine, hospice and palliative care, geriatrics. So these are the things you might think of that you could also be a primary care doctor and then do those fellowships and become board certified. Obesity medicine, addiction medicine, those types of things. You cannot be a pediatric cardiologist after going through a family medicine residency. Yeah, really, really good. All right. Well, hopefully, Arvin, we can send our, contact information out. We're happy to.
Yeah, of course. Yeah, I definitely want to be respectful of everyone's time. If we can maybe have emails in the chat, that might be useful for people who want to ask more questions or just interested in connecting. But yeah, thank you all so much for joining. I'll pass it off to Nick and Roy, who'll explain the whole certificates and attendance to just make sure you get your participation counted. But once again, thank you so much. Thank you so much, Dr. Jones, Sarah, and Dr. Haidar. We really appreciate your time. And yeah, thank you so much.
Yeah, happy to be here.
Thank you all, doctors Sarah and Andrea, for coming on today to present. I'm sure the students found it insightful and took at least one thing to apply to their future goals. And also thank you all to the participants for coming here today. And as Arvin mentioned earlier, we are going to have future specialties come into this Zoom call to do more panels. So if that's something you're interested in, be sure to be on the lookout for any emails. And as for the certificates for participating in this panel, you'll all receive a copy of your clinical insight certificate by next week. And you can all feel free to utilize this certificate as qualifications on your resume or med school or any health-related program application. And if you haven't received the certificate in, let's say, 2 weeks from today, please feel free to contact me in the email that I will drop in the chat, and we could get that sorted out. And yeah, Roy, if you want to talk about the attendance.
Yeah, yeah. Make sure to fill out like the Google form that I believe was sent out to each one of you. And then feel free to like write down the any improvements that we can make for sessions in the future, as well as just like other specialties that you will be interested in. And we hope you really enjoy this session.
Thank you all.
Thank you. Bye.
All right, thank you guys once again.